I think we should get started now. So hello everyone, my name's Tom Ayers. I'm the Director of the National Collaborating Centre for Mental Health. Just to say who we are, with the National Collaborating Centre for Mental Health, we are part of the Royal College of Psychiatrists, but particularly in relation to this, our work, we've done a lot of work over the last few years, 7 or 8 years now, running national improvement collaboratives across the NHS and other sectors. The biggest of those programs that we're doing at the moment is the Culture of Care program, which people may be familiar with. But we're here today to talk about wave 2 of our demand, capacity and flow QI collaborative, which we are open now for people to join. So I'm going to chair the session. Really pleased to be accompanied by colleague Amar Shah, who's our national improvement lead, but also as of earlier this year, also the national clinical director for improvement at NHS England. And Chief Quality Officer at East London Foundation Trust. We'll have a couple more people from our team talking as we go through, but I will perhaps introduce, so Renata and Adele, but I'll perhaps introduce them as we get to that. So we're going to start by running through some information about the programme, and then some a little bit of trying to give you a little bit of a feel about some of the teams who were part of the programme in wave 1, and then we're going to open it up to a Q&A for the programme. So I'm going to hand over to Amar in a second, but just very briefly, this is a picture of collaborative members in wave 1, which ran with 19 teams from mental health services over 18 months from January 23 to July 24, and we are launching. We think we got a lot out that we were able to have a good impact with that, and teams got a lot out of it. And so we're launching wave 2, which starts in January 2025. And actually, one of the things that we're changing, and we'll perhaps come to this as we go through, is that it is now going to be a 2-year programme. So it's January 2025 until December 2027. So I'm going to hand over to Amar now. He's going to talk a little bit about the theory around this work, and then I will talk about what our sort of offer is, and then Renata and Adele will talk a little bit about a couple of teams last year, and then we'll open it up to questions. So Amar, if I can hand over to you now, please.
Thank you very much, Tom. Hi, everybody. Thanks for joining. Just a little bit about how we want to support you and your teams to do this work. We know all of us are here probably because we have an interest in trying to improve access or manage demand in different ways, or think about how we reduce waiting lists for access to specialist care. That there's a tendency for clinical teams, when they're in the position of having lots and lots of people coming to them as referrals or long waiting lists, to really feel a bit stuck or feel a bit helpless and not know what else they can do beyond asking for more resource. And that was certainly our experience in East London many years ago. What we want to do through this program is equip and support clinical teams to really think with their service users about the whole pathway, and think about applying quality improvements and really good systematic understanding of demand and capacity and flow, to think about what we could do differently with the resource we already have that adds most value and gives people access when they most need it in the service. So it's really taking the approach of quality improvement, which is let's really unpack this complex issue, understand it from different perspectives, but then apply the discipline and the science of improvement and the principles of managing good flow to help the teams start to gain greater ownership of the system in which they work, and start to think about things they can actually influence and try differently, and test those ideas out in a safe way using plan, do, study, act cycles, and use data to really inform the way they're going about this, not only to prioritize where in the system they work, but also as they test changes to really understand which things are leading to improvement, so that they know what to hold on to as practice in the future when they implement the changes. So it's many of you will probably be familiar with quality improvement and would be using it already in aspects of the care your team or your services are providing, and this isn't really any different. But what we will be doing through this program, and learning from the first cohort, is making sure that teams are really well supported to do this, have a good structure in place, are really co-producing this work with people with lived experience of the service so that they can really start to challenge current thinking about what the best service model looks like, and think differently about that, and have close improvement coaching support and close leadership support, which is sort of really critical to giving this work a chance of success. But we've had really great examples of teams from the first cohort that have tried something new, have gained really great insight into their own service through really simple things that you and I might expect that teams are aware of, but actually simple things like mapping the process can give great insight about what actually the steps are that everyone should go through, which steps really we're not sure about, which steps don't add a lot of value that we could start removing, and really starting to use the data in more sophisticated ways to predict demand and think about how your capacity could match that demand. So it's the good principles of good operational management and flow management with really good quality improvement method applied to it, and that's our theory about how we want to support you and your teams to do this work.
Thanks, Amar. So I'll just talk now a little bit about what that looks like in practice. So we, as Amar said, we're using tried and tested quality improvement methods, and we've adapted the approach to be obviously focusing on this specific thing, looking at demand, capacity and flow, and we've kind of learned a lot from the first wave and have tweaked our offer a little bit as a result of that. So the place that we start, the overview of the collaborative is that, as I said, it's 2 years. One of the things that we did in wave 1 that we've changed for wave 2, apart from the length of it, is about the types of teams that we are asking to join the collaborative. So in wave 1, we said any team in mental health who has an issue with demand, capacity or flow can join the collaborative. From our learning in wave 1, both in terms of the types of team who got best benefit, but also I think where we had I suppose by chance, similar teams from different parts of the country come to the collaborative, and we really saw the value of learning those teams working together and learning from each other as they went along. We made the decision this year to actually specify a smaller number of types of mental health services that we are targeting. If you are from a different type of mental health service or would like to put a different type of mental health service into the programme, please do contact us and have a conversation with us about that. But our starting point is these ones. So that's children and young people services or CAM services, talking therapist services, and really we're talking about psychological therapists across the whole pathway. So talking therapies for depression and anxiety, formerly known as IAPT, but also psychological therapies in SMI or in secondary mental health care services, and then finally autism services. So we know that there are issues around demand, capacity and flow in all those types of services. We know that they're amenable to the approach that we're bringing, and we think the opportunity for shared learning is there. Each team that's on the collaborative, and they join at a team level, will be allocated one of our skilled quality improvement coaches, and they will support the team to go through the whole process over 2 years, which I'll talk through in a second. But then what we will do every quarter is bring the teams together for in-person learning sessions as well, and there will be other opportunities for shared learning in between those quarterly ones virtually. So if we go to the next slide as well, please. So the first bit of the method is, as Amar said, to really understand the current system and to go through a fairly detailed process of process mapping the current system, and then looking at using the data for teams to understand the data flow through their service and where the bottlenecks and blockages are. So identifying where are the places that are most amenable to intervention with this work. This in itself has been a really powerful tool and start to the work for teams, and that's an example of I think a relatively complicated flow chart that one of the teams came up with to map out their system, but even some of the more simple flow charts can be really powerful in terms of people visualizing what's actually happening through their service. So if we go to the next slide, please. What we'll then do with each team is to support them to develop their own theory of change to intervene in their system in the place where that will have the biggest impact. It might be at the front door, it might be about flow through the system, it might be about maximizing available capacity. we'll support people to develop their change theory along with how they will measure that, and what changes they will make to in order to change, and we'll support teams to test those changes throughout. This phase of the project is about 18 months, of testing a range of changes to lead to sustained improvement, and we'll have a data platform that will help with the measurement as well. We'll also support teams with lived experience involvement, which is actually critical to this work, and think about equity within their work. So in the sense that if you don't focus on equity when trying to make improvements, there's a risk that you actually make things maybe better overall, but increase the inequity within it. And as I said, we'll have collaborative learning sessions where the whole thing really comes alive for teams. If we go to the next slide, please. Okay, so I'm going to hand over in a second to Renata, who's going to give the first sort of story from Wave 1. Renata was one of our coaches on Wave 1, senior improvement advisor in the team. Before I do, I just want to say, because we haven't published this on the website, and there's a reason for that, which is this is a subscription collaborative. So teams all in Wave 1 subscribe to be part of the collaborative, and it's the same in Wave 2. We haven't finalised the pricing for it. And the reason for that is that we're trying to bring the pricing down as low as we possibly can. At the moment, we are pricing it at £10,000 across 2 years. So that's £5,000 a year, and that can be paid in different ways through instalments or upfront. But we are working at the moment, and we certainly should be able to confirm this by the end of October, and the sign-up process is at the end of November. What the final price is. It won't be higher than that, but we're working to try and make it a lower price, because we don't make a profit out of this, but we obviously have to cover our costs, and we really want to sort of maximize people's chance for improvement across the system. Obviously, we're aware that budgets are tight everywhere, so we want to make it as affordable as we possibly can. With that, I'm going to go to Renata, and Renata, you're going to tell us about some work that was done in Kent in Wave 1 of the programme.
Yes, thanks, Tom. So as Tom said, hi everyone, it's lovely to see so many people on the call. My name is Renata Souza. I was a quality improvement coach on the collaborative and supported five teams across the programme. And one of them was the community mental health team in Kent and Medway. We're a lovely team to work with. So I'm really pleased to be able to share, a brief overview of their story on the programme. So if you can move on, lovely. So initially the project was focused on the community mental health team, but they very quickly brought the psychology team into the work because they felt, it was a really good opportunity for them to better integrate the two teams. So we did all that process that Tom and Amar described. So the flow charting process was really helpful for them to really kind of think about the different steps and the complexities of their pathway as well. So a lot of the people in the meeting didn't really know about the different steps that they had to ask each other. So it was really helpful for them to do that exercise together. So they looked at some data, reflected a lot as a team, and then identified their key priority areas for their project to start with. So the key bottlenecks for them were around the decision-making process. So they had one weekly meeting that was really long, with the multidisciplinary team, 3-hour meeting. Everyone felt the meeting was really difficult to be part of. Quality of case presentation varied a lot, which impacted the decision making. So they really felt we're not using the resources that we have in the best way. So they thought a lot about this and tested. So Matt, if you can just click again. So they thought about some key things that they could do differently to better use the resources and the expertise in the team. So here on the screen, I'm just sharing the key ideas that they tested that had the biggest impact, but they did lots of other small things. So one of the things was to kind of split that decision-making process, maximizing the expertise in the team and capacity. So they started to have these weekly discussions, like 3 days a week with the medics, straight after the assessments had taken place, to really improve the decision-making process and kind of being able to feed back to the patients as well more quickly. Also, using the expertise of the psychology team, they started to hold weekly spaces for clinicians carrying out assessments to really discuss the cases for psychology with the senior members of the psychology team. And that really provided a space for learning as well. So the psychology team had time and space to connect with the clinicians carrying out assessments, to really discuss and explore different options with them. And also they had an initial intervention process that lots of patients went on to, like, for 4 weeks. And then all that was then sent back to the MDT for decision making for the next steps. So they set up these initial intervention supervision spaces, where once patients had been through those initial interventions, then they could make the decision there and then, again with the psychology team, in terms of the best next steps for the patient, rather than having to go back to the list of the multidisciplinary team meeting, which was creating a huge backlog. So they had 30 people on the list for discussion in the MDT meeting, but only 20 people could be discussed because of time pressures. So, and that, build up on their waiting list. So the key aim for their project was to try and reduce that waiting list, which they call an active review, by 50% by the end of the program, which was June 2024. So Matt, if you can move on to the next slide, please. So they saw a huge impact from their work in a very short space of time. So all the new spaces that they created for decision making provided an opportunity to educate staff, but improve team cohesion for them to work better together as a team. And I could see that through the meetings as well. They were coming together in those protected spaces to have reflective conversations and action on things together. So the MDT meeting was reduced by approximately 2 hours. So we went from 3 hours to 2 hours. And they got feedback from the experience of the MDT, which at the beginning was like really difficult for everyone, that how much they had improved. And then they used that freed up time from those MDT meetings to then deliver reflective sessions on how to, on formulation and to improve the quality of assessment and how the cases were presented as well. So there was an impact on the, and if you can click on again, Matt. So you can see that there was a huge impact on the waiting list. So they saw a reduction of nearly 50%, which was their aim, on the number of people waiting from the point of assessment to the decision-making process to then start treatment or be discharged to primary care. So they really, I think for me with this team, they really saw the potential of the team and the resources they had, and really made some changes that had a huge impact on the ways that they were working together, but also on kind of that waiting list. And I think for me, what motivated me a lot working with this team was to see that they saw this process as the beginning. So they were very keen to continue the work, using the spaces they had already protected to have meetings. So one of the reflections they had was that they knew that all this work had to be done, but they never had the time to come together to do it collaboratively and also have the support to do this in a more structured way using quality improvement. So it was service user involvement was an area that they were always reflecting on, but towards the end of the project was a priority area for them to take forward. So they saw that as an opportunity for them to be the innovators within their area and go through the hurdles of the trust kind of processes to kind of involve people and thinking more creatively around that, and also areas of equity. So I think this is very quickly kind of an overview of the team's work. So I don't know, I think I've got this.
Thank you so much, Renata, for that. And what I really like about this team's work is it's quite a technical thing where it comes down to that chart which is showing raw numbers. It's really important that we see an impact on that, but actually the work they did really also impacted on the experience of the team, the skills of the team, and the sort of cohesion of the team. And I think that's what this approach is trying to do, isn't it? Is to bring like human changes, which one of the outputs of that is better efficiency of flow, but actually there are a load of other benefits as well. And I'll perhaps hand over to Adele now, who's same role as Renata, and she's going to talk about work with the Talking Therapist service in Hounslow.
Thanks, Tom. Hi, everyone. I'm Adele. I'm a Senior Quality Improvement Advisor and also someone who had the privilege of coaching teams on Wave 1 of demand capacity and flow. I would love to tell you the story of Hounslow Talking Therapies, a team in West London who, through curiosity and intention with a sprinkling of QI methodology, now provide each person who is assessed by their service with an outcome of their assessment within 7 working days. Next slide, please. Now, sometimes when we're talking about demand capacity, and flow. It can feel process driven. So there might be a spreadsheet, there are some numbers, there are some percentages, all of those things really important, of course, but sometimes this work can become a little bit abstract and removed from connection to the people we're talking about. So that's what I want to hone in on with these guys' story. And for this team to really understand how much of a difference they made, it's important to connect to the human stories. And that's something that we hold on to when we're delivering this collaborative, and we root all of our core coaching in stories. So the stories of teams and the stories of people that are using the team services. So I'd like to take you to the end of Hounslow's journey, actually. So their data showed 2 significant shifts in the direction of improvement and a final achievement of 100% of people receiving an outcome of their assessment within 7 working days. But what do those numbers actually mean for people in the borough, right? People who are in need of some support and space to talk and be heard and to recover. So I'm just going to take a moment, if you don't mind, to share with you Hounslow's story, who was written by Sue Lewis, their lived experience colleague on the project team. Every client is in limbo from referral to having the initial contact made. It's tough. You just hope that you hear something soon, and when you do, it's one step forward on the path to feeling a bit better. Yes, it's part of a longer journey, but it's a really significant step. As for the team itself, it's really motivational for them to understand and embrace what's been achieved. Although the project team have worked with commitment and diligence to bring this about, everyone ultimately can enjoy knowing that clients are being helped quicker. It's all about people at the end of the day, and clients and the Hounslow Talking Therapies team. The team typically get 800 referrals on average a month. That's a lot of screening to work through, and I'm sure the positive results of this collaborative will lighten the process if it feels daunting at times. It's a 360 win-win for clients and the whole team. I thought that last sentence resonated, and it really spoke to me for the whole collaborative. It's a 360 win-win for clients and the whole team. So that story and outcome achieved in wave 1 feels like a bit of a balm. The team reflected on this, a bit of a balm, like a bit of an antidote to lots of the rhetoric around broken NHS systems. And actually, with some time and permission and resource, and again, a sprinkling of QI support and methodology from us, they made a real difference in their borough. Next slide. So let me just take you back to the start of their journey in January 2023. They formed a project team, so a range of clinical professionals and experts by experience. You can see them on the screen here. CBT therapists, PWPs, assistant psychologists, and I think having that range of experience really helped them thrive and gather different viewpoints. Next slide. Renata and Amar reflected on this, but really we began by visualizing their system. We mapped out in loads of juicy detail, figuring out where the bottlenecks were, and we honed in. You can take a little look on the slide. So teams had a lot of fun, like realizing just how messy systems are often. It's the first time that everything in all of its glory is mapped out, and you're kind of confronted with this intervention in itself. And for this team, actually, their system was working efficiently in most areas. A referral comes in, is screened, a person receives an assessment, they start treatment, and then they leave the service thereafter. Next slide, please. But actually, when we looked at their data, I've taken this slide from one of their presentations they gave, actually. When we looked at their data, we saw that they were providing people with outcomes within 7 working days, on average 80% of the time, but we needed to drill down into that average a little further, and we could see that those that were receiving step 2, so a less complex, simpler assessment, was up at 93%, but for those requiring step 3, just the type of screening where a person gets a higher tier of support, it was down at 37%. So this data spoke to us massively, and actually they formed their QI project off the back of this. Next slide, please. So to summarise the team's project, really, they tested 2 smaller change ideas. Then they focused on this bigger change idea where they merged 2 complex stages of screening into 1 simple stage for every patient. That was to streamline, improve efficiency. They ran PDSA cycles, they learned, they adapted, and by June 2024, they wanted to do 95, but they were providing 100% of their clients with an outcome within 7 working days. And the team still meet, guys, They've sustained their methodology, they present their work regularly, and they've been a real highlight from Wave 1. Thanks, Tom.
Thanks so much, Adele. Yeah, that's lovely. So thank you. So hopefully that's given you a flavour of, if we just perhaps take the slides off now, Matt, thank you. We'll put that one up before the end though, don't worry, it's got some important dates on it. But I think that was all that we wanted to start with in terms of information giving, and that we would now sort of open the floor for questions. I suppose as said, the purpose of this session is a Q&A for people who are interested in joining. Hopefully wave 2 of the programme, we're keen to have as many teams as we can on wave 2, and at the moment we're planning to begin that in January, with the registration window going up to the end of November. To preempt any questions, if people needed a little bit of extra time to be able to make the decision to join, we will be able to accommodate that. But I'll open the floor now to see if anyone has any questions or reflections about that. Sharon, thank you for.
It might not be that helpful, but I'll have a go. We have quite significant challenges in our autism and ADHD services, and it would be really helpful to think about how we could implement something like this, or just think about this within our services, because it's something that I've been talking to commissioners about for 5 years now, and we're not any further down the line. And there's no money, so we need to have a think about how we address the significant waiting times and the significant volume that's coming into services. So I'd be really interested to think about it from our point of view.
Thanks, Sharon. So we did have teams on wave 1 from Autism Services. I don't know, Amar, if you wanted to respond at all to that.
Yeah, sure. I mean, there's no doubt that the long-term solutions for this are going to need to include a really good understanding of population need, and predicting that over many years, and then thinking about the whole range of community assets that might be able to support people. And so it's a redesign of the system as part of a planning conversation, which will include things like funding and resources. It's probably what's going to be needed in the long term, Sharon. But my sense is, and from work that we did with teams in cohort 1 and the autism services in my own organisation in East London, there's actually quite a lot you can do with the resources you've already got to give people faster access to the specialist care and meet their needs better. And for me, that's got many benefits. That's first of all demonstrating that we're doing the absolute best we can, removing waste, really adding value, helping understand what the optimal service model is that could then feed into that kind of larger redesign process. But also, really importantly, it gives the staff working in those services a little bit more ability to feel like they're in control of what can otherwise feel like an almost helpless situation. And actually, we really saw that with the autism teams in cohort 1, that they started from a position where there's nothing they can do and it's just down to funders to solve this, to actually realizing there were some things they could do, and actually having some control of that gave them back some autonomy and improved their own experience at work. So it's not the full solution, Sharon, we understand that, but I think it's an important part of the solution.
Yeah, I think there's something about a system shift as well. So one of the things that we've talked about in our trust is, does everybody absolutely need to have a diagnosis, or can we think about needs and how we address needs and thinking about that instead, particularly for some of the individuals that we have in inpatient settings where they might be too unwell actually to have an assessment anyway. But you can identify needs and you can go forward thinking that this presentation might be part of their overall presentation. So let's adapt and adapt care and care plans to figure that in. So I think you're right. I think there are things that we could do, but it becomes such a big thing because the waiting list is so long and because the volume coming through is so high that you just get really stuck, don't you?
Yeah. And I think one of the so we work on other programs, and we you potentially bring that expertise into this program as well with a great partner called Neurodiverse Connection, who are a user-led organisation, obviously with a big focus on autism-informed approaches, and I think there's also a lot of things that can be done to support autistic people while they're waiting or even in the process of waiting. But I think, as Amar said, another big benefit of this approach is really understanding what your true capacity is versus the demand that's coming through, and being able to say, actually, we are doing everything we can, and here's the evidence, and I think that can support those conversations at a commissioning level as well, because I think it's undoubtedly in some services more investment is needed as well. Al.
Just wonder if you could share some light on the size of the teams that you're working with. I suppose we've got an issue that we've got quite a lot of teams and a lot of services that are all facing substantial pressures. And like Alison, we've got particular bottlenecks around autism and ADHD. In my mind, I was thinking about bringing two teams together, so two separate teams, albeit focus on the same kind of condition to improve patient flow. Is that something that would be possible, or is it? So I suppose go back to the initial question, what's the scope and size of the team you're looking for?
Do you want to? So I think there's a balance, isn't there, between maximum benefit, and I should say, I know this wasn't your question, but the other thing is that we always offer sort of a discount for multiple teams from the same organisation as well. But I know that's not the question you're asking. But I think there's a balance between maximum breadth of benefit with being able to do the work in the right depth, isn't there? But I don't know, Amar, and then perhaps Adele and Renata might want to give a view on working with teams and how that sort of felt as well.
Yeah, it's a difficult question to answer really generally, but maybe that's the sort of thing we could pick up afterwards and think, what is the challenge you're trying to solve in your place, and who are you thinking you might need to be working together to solve it? Obviously, we would want to be coaching directly a group of people who are representing different parts of the system that can help you solve that problem. So if that group becomes too big, it's very difficult to work together, because it's much more complex and takes a lot more effort. So as Tom said, it's a bit of a balance, but maybe that's the sort of thing we could think through with you if you're keen on joining this, to think, what's the right group of people from different parts of the pathway to do this work.
Thanks, Amar. Oh, Adele, were you about to come in?
In terms of wave one, it might be helpful to hear a little bit about the types of teams that Renata and I worked with. So it was about 6 to 8 people from a service, from multidisciplinary backgrounds, administration, OT, psychology, psychiatry. And that worked really well when they could come together and meet with us. We do it quite intentionally to get teams set up, longer sessions, and then it looks like an hour every fortnight online, which felt quite accessible for our teams.
Thanks, Adele. And obviously, when we're working with community mental health teams, there can be some quite large teams, but obviously then that smaller project team that we're actually working closely with. Kerry.
I was wondering about kind of interfacing with sort of existing quality improvement teams within a trust. So I know for the trust that I work with, we do have quality improvement coaches, we do have quality improvement teams. And there's quite a focus on quality improvement. I'm sitting here as the quality improvement chair for our local hubs, and a quality improvement coach as well. And I guess just thinking about how you kind of tie those things together with this support and this approach.
Yeah, thank you, Kerry. So it's, as you can imagine, and actually this has changed somewhat over the last 6 or 7 years, from this being maybe an unusual case where an organisation had the quality improvement team established, to now a much more common situation in organisations. And so we commonly work with improvement teams. Obviously, we're coming in as additional resource, and neither us or you would want that to be duplicating or doubling up with resource that you already have, but I think can really usefully work with existing quality improvement teams, particularly thinking about, and then how is this spread across other teams? How can this be sort of supporting a local quality improvement team to do similar work, perhaps with I'm just repeating myself, with other teams in an organisation, and we work. So our coaches are all trained in model for improvement, which is quite a commonly used approach, but obviously other approaches are available, and we always would flex to work. Find a way of work that they will have more in common than not, don't they? And so we work with we've got plenty of experience of working with quality improvement teams using different methodologies as well. But yeah, we would, to be honest, it often strengthens the chances of success if there's a local quality improvement team involved in some way, obviously without just doubling up on resource.
Can I share just very quickly? Because pretty much every team that we worked with, we had an internal QI lead or coach who was kind of supporting the work as well. And I found it really helpful because they understand the context that we are not part of, but we bring that kind of national structure to the program. And in the end, I think the internal quality improvement coaches or leads decided that they wanted to meet with the other leads across the program to see how they were all supporting each other. So we then facilitated a space for all the different internal QI coaches or leads to come together. And it was a very kind of helpful space for them as well to understand across the country, how is everyone working? But also what Tom said, often the internal QI coaches could really think about some initiatives that were happening across the trust that could actually feed into the work. So they played a key role. So it was really helpful working with them, actually. So.
Thanks, Renata, for saying what it actually looked like in practice rather than my more abstract answer. Jazz has put a hand up as well. Jazz is another of our quality improvement coaches who worked on the programme.
Thanks, Tom. I actually was then going to put my hand down because Renata completely said everything I was going to say, but I certainly found working with the internal QI departments really, really helpful for all the reasons that Renata said, but also the sharing of the work afterwards and being able to support the teams in continuing some of the work, because there was a real sort of passion and drive, and that's we hope, and I know a lot of the teams have continued with some of that work. So then having them on board throughout the programme allowed them to sort of know what process the teams have been through and help continue some of that. So those are positives from having internal QI support.
Yeah, thanks, Jazz. I think it's worth saying that one of the reasons we've extended the length of this programme is because so many teams didn't want it to end when it ended, so they didn't feel they quite got to the end of their improvement. I suppose you never get to the end of the improvement journey, but they had more to do here, and we kind of agreed that actually a little bit more time embedding that would increase the sort of sustainability of the programme as well. Nikki.
Hi, yeah, I was just wondering about the idea of users with lived experience and how they're included, particularly within CAMS. I'm in CAMS in Northern Ireland, so I would be keen to think about that and how we might think about, because we have got users as young people, children, and carers, parents.
So those people are essential to all improvement, I think, in mental health care. And we ask that in every project team there are people with lived experience. We have a head of lived experience and a whole sort of infrastructure in our team in terms of bringing that perspective in, but we also really strongly ask that people have their own representatives within their project team, and we actually have a focus on that in every one of the learning sessions throughout the programme as well, about sort of people sharing how they're co-producing their work, and thinking about that. And we saw quite a lot of examples of change ideas that would just never have happened if it had been left to staff alone. Even simple things like what an appointment letter feels like to receive, and the way that that's written, and then the impact that can have on DNA rates is quite, I think, can be quite profound. And we saw examples of that in the programme. I don't know, Adele or Renata, if you want to add anything to highlight there.
Yeah, so it was an area that was quite difficult for a lot of teams because they hadn't worked in this way before. And I think for some teams it's quite new, kind of bringing the lived experience voice. But some teams have managed to do this quite well. And I think in particular one of the CAMS teams actually set up a working group of young people who then really helped them think through some of the key change ideas that they wanted to test. And I think the example they used, Tom, I think was a letter that was, I think was a pack or information pack that was co-produced with young people. And then as part of that learning community, so people coming together in person every quarter, then that learning was spread across the other CAMS teams. So the CAMS team I was coaching took that example and adapted to their own kind of service. So I think those spaces also, when people come together in person in London, can really motivate people to engage, lived experience and patients in a different way, so that we can really kind of motivate and help each other think outside the box a little bit as well as to how you're going to engage people in the work. So, Adele, I don't know if you have any reflections here.
Thanks. I'm glad you asked that question then, Nikki, because it's an absolute key area, and it's something that a lot of it's not as easy to. I think most people agree in principle, don't they, that we should co-produce their work, but it's not as easy to do in practice actually. And I think
practically, then does that mean that if my team joined this project, would I be able to have some families or some young people or some parents that wanted to be involved as having had lived experience? Would they come to the sessions with the whole team? Would they join for all of it, the whole process? Would it be in that way? It's not like it just come in for one part, it's that they would come for the whole thing. It would be totally all of us together.
Yeah, 100%. And the more that happens, the better.
Exciting to me. Yeah. Like I mean that, the letters it's my bugbear. I've been trying to do something with ours for years. I blow my gasket every now and then, thinking I want to change this, but I need a family to help me to make them wonderful.
So we have a letter that sometimes we present when we talk about the programme, where it started out and it was 2 pages of everything you shouldn't do, and if you did do them, we might discharge you from the service. And it was actually helpful information, but framed in a negative way, and it was turned around into a much more straightforward and friendly letter that suggested this might be a place that you might want to come for an appointment, and then to see that translating into a difference in actually how many people did turn up, and therefore using more of the capacity that was available, was really validating, I think, for the team.
Thank you.
Al, again.
I suppose that just sparks some extra complexities in terms of children and people, that they become adults. So how you hold a group for 2 years, particularly, or whether there's, or how you consider staging it so you've got a kind of succession plan in that. I'm spoiling the flow of the meeting because you're talking solution focus, and I'm bringing in negativity already.
No, I think problem solving is essentially what quality improvement is, so I think that's fine. If there weren't problems, it wouldn't exist. So I think absolutely. So I mean, there are different ways you can think about that. So I think it is okay to have someone on a project for children, young people services who turned 19 during the course of that, or 18 or 19 during the course of that project, and they're probably still in touch with the experience enough. But equally, and this isn't just for children and young people, there are different ways of utilizing in engaging with people with lived experience. So there are people on project teams, I think that's essential, but then actually also how are you connecting with current patients who will be by the nature of a project that's about flow, will change over the course of 2 years who the current patients are. So I think you probably will definitely be suggesting a range of methods to engage with service users that takes both consistency of someone being involved with every aspect of a project, but also sort of touch points with a greater range of people who will probably be different people throughout the life of it. Are there any more questions? Okay. So if we just put the last slide up again, Matt, just with the next steps and what we're sort of asking for people. So hopefully that's been helpful, and hopefully at the end of the session people are thinking, actually, yeah, this is something we want to be a part of. As I said, we will be finalising the cost at the very latest by the end of October, and I'm hoping to do it sooner than that. I'm going to say I'm hoping to bring it down, if we can, from the current cost, which is £10,000 across the 2 years. And we the deadline for formal registration is the 27th of November. And if you do register, like I said, one team or more teams from an organisation, what will happen is we'll obviously send you the documentation on receipt of that, and then have a welcome and introductory call with your improvement coach, probably in December or early January, and then there will be a launch event at the end of January for the programme, and that's in London. We really very happy to talk to anyone individually about the programme. Our email address is there, DCFQI. Is that a dot between the Q and the I? Can someone just confirm, or is that just the font of the Q?
Yeah.
No, there's no dot.
No dot. Okay. On mine, it looks like there's a little dot, but I think it's just the way the Q looks. So dcfqi@rcpsych.ac.uk, and we'll get straight back to you, and very happy to jump on a call about anything as well. Otherwise, we will continue to email you with any more information about the programme, including when we confirm the costs. And please look at all the information we have is on our website as well, which you've probably seen in order to join this call. So thank you very much for joining. Thank you for the questions, and hopefully we'll work with some of you over the next couple of years. And yeah, we're really looking forward to the programme. Thank you very much.
Thanks, everyone.
Thank you.
Bye.
Thank you.
Bye.